you so very much for the introduction, and I would like to thank the organizers for inviting me to have this opportunity today. Well, I'll be talking about fertility preservation in non-malignant gynecological conditions. Of course, making a lot of reference to what concerns us, mainly adenomyosis and fibroids. Well, I bring very warm greetings from Lagos, Nigeria. I was so intrigued during the dinner that I saw a masquerade also dancing here. You can see that is what we do also in Lagos, Nigeria. Well, I have no interest to declare, except that I have a lot of fertility bias. And I think that's going to show also in my presentation. So talking about fertility preservation, this is the process of saving or protecting reproductive materials or tissue in order to retain fertility or ability to procreate. In other words, is to postpone fertility. In this field, there's more data with patients with cancer, there's no doubt, because of the emergence of co-fertility. But to all of us seated here, we know that there's some non-malignant or benign conditions which either as a result of their natural cause or because of their treatment lead to premature ovarian insufficiency or infertility. Therefore, these are potential indicators for fertility preservation. Well, there's some articles on this. Edgardo Somigliana, this is an Italian group. They wrote about fertility preservation in women with endometriosis, and they asked the question whether it's for all or for some or for none. Another Italian group talked about the challenges of fertility preservation in non-oncological diseases. But this year, the French group, that's the Chaperon group, wrote about fertility preservation in women with benign gynecological conditions. So this is generating interest all over the world. And that's why I think it's something we should also look at this meeting. So my presentation today, we aim to highlight some of these non-malignant conditions and help us to take advantage of these seemingly missed opportunities for our patients who have fibroids and adenomyosis. But the question is, why do we actually need to preserve fertility in non-malignant gynecological conditions? And the key word is ovarian reserve, all right? When we talk about all AMH and all this, this is what we're all looking at. And this started from the groundbreaking work of Wallace and Kelsey in 2009, which was published in Nature, which showed that all women don't have the same, that when it comes to ovarian reserve, all women are not equal. Some have higher reserve, some have very low reserve, and some are just intermediate. And so we want to do anything to prevent a woman from pushing her from one level to another. Well, when we look at the indication for fertility preservation, there are many of them, but I'm going to look at the group that talks about other benign gynecological conditions. These are things that require that you postpone pregnancy. And we know that when we do high food, that's what I've been hearing all day. And I heard Dr. Chen asking the question, because there is always this debate between high food doctors and the fertility doctors. The fertility doctors don't seem to be too impressed sometimes. Because if you have a huge fibroid and after your treatment, it has reduced in size by about 30%, and the fertility doctor can still not get to the ovaries, is really not impressed with your treatment yet. And so those are some of the meetings we need to have. And for some patients, we might even actually consider preserving their fertility if you're going to go the whole hog of waiting for, let's say, about 1 year for you to achieve about 70% reduction in size. So what are these methods that are available? Embryo freezing, egg freezing, IVM, and ovarian tissue cryopreservation. This review also earlier in the year, this lady from Belgium, it was a review article, showed that oocyte vitrification appears to be the gold standard now of women preserving fertility, especially young women. But the question most of the time is how many eggs do we freeze? And that's one of the problems that, because I come across patients a lot and they say I've frozen my eggs, and I say, how many have you frozen? And they say 5, 6. That's a joke. For it to make sense, you need to store at least 15 to 20 eggs. And so from this graph, you'll see that the chances, if you are less than 35 and you store 10 eggs, your success rates, the baby take-home rate will be about 30%. But if you store about 20, then it jumps to about 80%. This, I can see the time really clicking. So this is the reason why you need so many eggs. The fertility is not very efficient, and it tends to just funnel down the line. I'm not going to go over that now. One of the things that you can also do is that this is an article from New York Times. It's not saying the same thing especially exactly, but it's telling us that a woman can use not only one method to preserve, you can use 2 methods. Either you're trying to combine both oocyte cryopreservation with ovarian tissue cryopreservation, or even using embryo cryopreservation. Well, IVM, I'm not going to go over that so much. Embryo cryopreservation, the only thing that we need to talk about is that for this is only applicable to women who are married, because there can be some legal issues if the marriage goes sour. The best way to store oocytes is vitrification. For those who do IVF, they know what I mean. Slow freezing is out of sync now when you're talking about oocytes. Yeah, ovarian tissue cryopreservation, the first baby was in 2004 by Donet. Right now, there are over 200 babies, and this is probably one thing that will probably catch up with us in the future. And I was just with, that's Professor Donet, the people who had the first baby, and Professor Dolmans. I was with them about 2 weeks ago trying to train on ovarian cryopreservation. Well, this can be offered in young patients. It's not recommended for women above 35. That's one of the things, the problems that we have with that. Now, in Lagos, we've done 322, but by the time I was preparing this, 321 patients. The mean age of these patients is 39 years. The age range was about 24 to 53. We started 2 years ago. Actually, I think tomorrow will make 2 years exactly that we started. Fibroids alone represent 87% of our patients. Fibroids with adenomyosis, 9.7. Adenomyosis alone, 3.1. Now, but the history of infertility in this patient is about 50%. So out of these 321 patients, 161 patients also have associated infertility, despite the fact that if you look at their age, they are not really very young people. So infertility and fibroids, of course, is something that we need to continue to look at. And that's why I'm looking at this thing that we need to talk about, fertility preservation for some of these older women who are going to go through this treatment. We know that fertility preservation is initially used for women who require cancer and age-related infertility. But it might be a good addition to selected patients seeking HIFU treatment for either fibroids or adenomyosis who are still seeking to raise their family. But in order to do this, for me to say this with a broad chest, we need to do studies that will consider cost effectiveness and also to look at the patient perspective. Is this something they want, or is this just an idea of the doctor? And this is the team in Lagos. Thank you so much for listening.